I think we'll get started, guys.
Awesome.
So on behalf of the AHNS Curriculum and Education Service, I really wanted to thank Ryan and Trevor for helping organize this session with moderators and panelists. And I'm going to hand it off to Ryan to introduce each of them. And I'm looking forward to a very lively conversation tonight.
Awesome. Thanks so much, Tony. So yeah, Trevor and I put together a panel today. The topic was TORS versus radiation therapy for oropharyngeal cancer. And we have some great guests here. We have Mihir Patel. He's first on my video list here. So he's head and neck surgeon, division director at Emory Winship Cancer Center in Atlanta. And we have Harry Kwan with radiation oncology at Johns Hopkins University. We've known Harry for a long time, and he's always a great guest and expert panelist on these. So we really appreciate his help as well. Then we have our three panelists who are going to present cases. Linda Yin from the Mayo Clinic in Rochester, my fellowship alma mater. So great to see her here. We have Molly Hefneal at Michigan, who has a couple more weeks of practice before she goes on maternity leave. So we're excited that she could squeeze this in to her busy schedule. And then Ray Wong at Baylor in Texas, who will be presenting our third case today. So I want to thank everybody for being a part of this. And we should have a pretty great panel here and three good topics. If the if the guests have any questions, please put them into the chat and I'll try to monitor that while we're going through the cases. And the questions that aren't answered already by the panelists and discussants, we will try to bring those questions up to the group to answer. Because I assume if you have the question, many of us have the question. So try to make it dynamic. So we'll start with Linda for the first case. And Linda, if you want to share your screen, if you don't have it up, I can share mine.
Are you guys
Yeah,
seeing it?
Yes.
we are.
Yeah.
And
Perfect.
just as a reminder, we're going to probably cut everyone off. Brian will probably cut each thing off at about 15 to 20 minutes so we can make sure that all of our presenters have time. And don't take that anything personal. It's just we want to give everybody opportunity.
Yeah. All right. So thanks everybody for having me. Thanks Ryan for having me. These are super helpful when I was a fellow, so excited to be on the other side. I'll jump right into the case. So this is a 51-year-old male, never smoker. This is a very common history for an HPV-related tumor. So I'll go through it pretty quickly. He had some antibiotics for bilateral neck swelling, lymphadenopathy that resolved most of his symptoms. But he ended up with some right neck swelling. So he underwent a CT and an FNA. This is the CT scan. The leftmost panel there does show a hyperdense small nodule in the right palatine tonsil. And then the other two panels, we're seeing some neck disease. And the biggest takeaway from the scan is to kind of look at this neck disease, and it's a cystic node, which we commonly see in HPV-related tumors. But how many nodes truly are involved in this area that we see, and whether or not there's any signs of extranodal extension, particularly into that sternocleidomastoid muscle and looking at that submandibular gland. And as we'll talk about, that'll be the focus of my case. So he did undergo a core needle biopsy that showed squamous cell carcinoma, P16 and HPV-ish positive, and had a high preoperative NAV-DX, as well ctDNA of HPV in the blood. This is his PET CT. Again, we're seeing the right FDG avid area in the right palatine tonsil. The neck disease has some peripheral FDG avidity. Centrally, the cystic portion is not avid, also commonly seen with centrally necrotic lesions here in HPV positive nodal disease. Interestingly, he had a couple of other mild, small FDG avid lymph nodes, one of which you can see there's really in level 5, and that's quite unusual for HPV disease. But the considerations here really, when we think about whether or not to take somebody to surgery versus treating them definitively with chemoradiation, at least and I think a lot of people do think about the nodal disease as often being the driver of how much adjuvant therapy somebody needs. The goal of surgery, hopefully, would be to avoid giving somebody standard of care triple modality regimen, especially, yeah.
Yeah, let's take a break and look back. What was your exam like on this node? What are you looking for on a node you see a patient? I mean, because looking at the scan, this looks like a chip shot surgical candidate. So, what steers you away from surgery and towards RT? What are you examining and feeling for?
Yeah, so you want to feel if the node is mobile. That can tell you a lot of information. Mobile lymph nodes would suggest that it's easily, dissectable away from surrounding structures. And whether or not that's a sign of E&E, a good sign of E&E or not, we can talk about. But in this case, on his particular exam, it was pretty mobile from the sternocleidomastoid muscles. That was part of what convinced me. And I felt that it would be, as you said, more of that chip shot category.
Yeah.
It was not, I will say it was not, these slices probably don't do that justice, but it was not super mobile from the angle of the mandible. But I do think that can be difficult in a larger node like this. It's just, you'd have to have them crank their head kind of all the way to the other side and feel. But that was the only thing that gave me a little bit of pause, but otherwise pretty mobile.
Okay. Anything else that would steer you away from surgery in somebody with an isolated node, a pretty lateralized tumor, other than, the fixation of the node? If this node's mobile, are there any other patient factors that would steer you away from surgery?
Yeah, I think if there's any signs on the imaging of any connection between the nodal disease and the oropharynx disease, even if it's a single node, that would not be favorable.
Yeah.
If there's any
pretty
signs
clear here. Yeah.
Yeah.
So Mihir, say this patient's in your tumor board right now, and Harry, what are your thoughts and considerations? This patient hasn't had surgery yet, right? You're presenting him at tumor board. So what's steering you one direction or another?
I know that the common point in our tumor board is to always ask, trying to minimize the number of modalities. And I get it that that's certainly one measure of essential impact on patients. I think that that's ultimately what we're trying to do. But when we think about it, compared to sort of the standard where that is, unfortunately, bilateral chemoradiation, which probably causes the most side effects. I sort of want to think, and I don't think our field is exactly there yet, but I sort of see is what is the best treatment approach as trying to minimize some of the long-term effects of radiation, if not no radiation at all. And to me, that is the ideal. And I think in this scenario, given the node, it's harder to believe right now that we're going to be able to get away from some radiation. And so the other consideration then is this a case where I can potentially just treat with one side of the neck? And I think that the lateralized, and it comes down to how we think about the risk on the opposite neck. And I think the weight of the evidence now compared to 10 years ago is that it's probably driven more by the primary in terms of how close it comes to midline mucosa, and less about the nodes, although there is still some controversy about E&E itself driving that. And so that's how I sort of start thinking about these cases. And where we tend to see most of our failures is actually in the neck as opposed to the primary. And to me, that kind of observation has always been consistent with this idea that the drivers of metastases fundamentally can sometimes lead to resistance to our radiation and chemotherapy. And so this is where I tend to favor surgery for if it's mainly if there are large nodes, but it's a lateralized tumor. But I get the whole story about E&E. And I think it comes down to ultimately what pathos will show us with regards to the value of the need for concurrent chemotherapy as part of that overall equation, right? because
Yeah.
ECOG certainly illuminated in the intermediate cohort where we allowed like less than 1 millimeter of E&E, micro E&E, which is another conversation. Certainly show that we can control it with just radiation alone, if not 50 gray. And so I think that those are the things that go through my mind when I think about this.
Right. So Mihir, at your tumor board, are you worried about 3 modalities versus 2? Do you think 3 is worse than 2 in all situations?
I don't, and I think that when you distill it and simplify it to 3 versus 2, I think you're doing the emergence of treatments at a disservice. Especially when you talk about a disease like HPV-related disease that has a high sensitivity to what we can consider, for the most part, fairly low toxicity treatments when you think about immunotherapy. Of course, the ones that do have toxicities can be extreme, but they're pretty well reported in terms of percentage and treatments and things of that nature. So when I think about it in that way, I think that's a tough argument for me to just use that for a reasoning for not offering surgery in most situations. And in fact, the DART trial has done very well offering trimodality therapy. So, and minimizing morbidity or especially quality of life. So I think that we just need to think about it in a different way, change our perspective, particularly when we think about targeted agents and vaccines that are coming to fruition for treatment.
Great. No, I agree. I think, 3 is only worse than 2 if they're getting full dose of all 3. If you start eliminating chemo, or if you start decreasing the volumes and the doses of the radiation, you're not comparing the apples to apples. You're starting to compare different treatments, so 3 might not be worse than 2 in all situations. So Linda, you got this patient, you don't know if there's E&E because you haven't taken it out yet. It's a fairly mobile node. What did you guys ultimately do at the Mayo Clinic?
Yeah.
Can I chime in real quick?
Yeah.
Sorry, Linda, just one thing to think about, and I think I don't want this to get lost in the explanation that Harry gave, is that if you ask a radiation oncologist, are you going to radiate both necks in this particular situation when you're talking about a tonsil cancer? What would you do? And the point he made very subtly, if you didn't pick up on it, is that there are radiation oncologists that will treat these cases. If there's concern for E&E, they will treat both necks. And that is something that at our tumor board that we talk about very heavily, because if we were to operate on this patient and did not demonstrate E&E, you're talking about ipsilateral neck volume radiation.
Yeah, that's very institution dependent. I think we'll talk a little bit more about that, but I think Wade Thorstad here at WashU has written a few papers and done some prospective trials on the bilaterality of radiation treatments for lateralized tumors, and has not found too much benefit to treating the other neck, even with E&E. But that's you're going to get a lot of variability to that depending on your institution. So Mihir brings up a good point that the treatment modalities you choose may be institutionally dependent. And what I do here at St. Louis and WashU might be different than what my colleagues in St. Louis do at St. Louis U. And one's not right or wrong. It's just different treatment options. So Linda, why don't you go to your next slide and tell us a little bit about, what you were planning here.
Yeah. So I talked to Mihir gave a good lead in here, because I want to talk about, we have a different de-escalation regimen here. I fully agree that we shouldn't think of it only as dual or triple modality. DART, which is the de-escalation regimen we give here, which is 30 to 35 gray with concurrent dose of Taxol, is a triple modality therapy, but a clear de-escalation of the standard adjuvant therapy. And so we do have active clinical trials using that regimen. So he ultimately elected to enroll in one of those trials and undergo surgery. His final pathology showed a pretty straightforward tonsil tumor. and then a single lymph node, 4.5 centimeters without E&E. The other interesting part is that there are some of those other avid lymph nodes is probably related to some granulomatous disease and not at all related to this cancer. It's only to point out that sometimes the imaging can be misleading too, even in the number of lymph nodes.
Yeah.
But as a part of this trial, we get to immediate and 2-week postoperative NAFDX, and his were negative, so he's getting observed on trial. I'll go through some of this really quickly, but just showing that can preoperative imaging accurately predict E&E? As Mahir said, that this is important too in patients who go on to get definitive therapy in terms of determining whether or not they have E&E and extended radiation treatment. But the long story short is that it's quite poor. Both CT and PET are quite poor at predicting extranodal extension. There's several studies that show this. This one's out of our institution here. This one is out of the Toronto group. This is showing it in the opposite direction. So there's a lot of occult E&E and nodal disease that do not necessarily show up on preoperative imaging. And then finally, this is out of the Emory group, Dr. Patel's group. So this is asking if radiographic E&E predicts prognosis, and the answer is not really either. The last thing I want to show is to kind of allude to what Mahir talked about. So this patient is enrolled in DART, and we think about E&E, we're going to get into 3311 with Molly's case as well. But even on our DART regimen, this is now public data that's been shared at meetings. So we're going to publish our 5-year outcomes from the second round of de-escalation trials. And this is a single node with E&E cohort. And the long story short is that at 2 years, we saw this group do really well with de-escalation. But now at 5 years out, and we're working on publishing this, that there is a difference here between de-escalation and standard of care. So it seems that any E&E does appear to matter. And so we are not de-escalating these patients off trial, certainly. And then on trial, it'll depend on their postoperative NAFDX.
Linda, can you remind your colleagues the de-escalated dose on the DART trial?
Yeah,
because
so
that's
it's
important relative to, for instance, 3311.
Yeah, so the DART regimen uses 30 gray with BID fractionation, so given over 2 weeks. 30 gray with docetaxel, 2 doses given concurrently. That's in the group without any E&E. In the group with E&E, so including the single node E&E cohort, we were giving 35 gray, similarly over 2 weeks with docetaxel.
Awesome. I think we need to wrap up that discussion, but I agree, E&E on imaging is obvious when it's obvious, but when it's not, it's really hard to tell. And that's one advantage of patients that can tolerate and have surgery, both from a functional standpoint and oncologic standpoint, that you do deliver their overall treatment package based on pathologic results and not radiographic results, which can be more challenging, as you showed in those studies. Mahir, any closing comments on that, or should we move on to the next case?
Let's move on. I think that was well done.
Sounds good. Thanks, Linda. Really appreciate that. Great patient. I'm glad they're doing well. Molly, you're up next.
Can you see the screen?
Sure can.
Okay. So just get straight into the history. This is a 56-year-old male. He is a current smoker, 1 pack per day for at least 30 years, and he presented with left throat pain, otalgia, and a left neck mass. Otherwise, he's relatively healthy, just some hypertension. And when he was seen in clinic, he had a 3-centimeter left level 2 neck mass, and on nasal endoscopy, he had an enlarged left tonsil, but there was no obvious lesion, just some asymmetry in the tonsils. He was initially worked up by one of our colleagues in the community and saw he had this sort of left tonsil mass on CT with, they called GTS extension, and this 2 by 3 centimeter necrotic left level 2 mass. He had an initial FNA, which was non-diagnostic, which is, again, is pretty common for these cystic nodes, and then was referred to us. So I biopsied him in clinic, and it was positive for squamous cell. His initial, it was, still pretty cystic. So his initial P16 was negative on those cells. And they said the HPV in situ was equivocal. But then he had a positive NABDX. So we sort of, from there presumed this was an HPV mediated disease and discussed with him treatment based on that.
So just to pause there really quick, Molly, could you see the tumor in the tonsil?
It was mostly just like a enlarged left tonsil. You could feel it. It was pretty firm, but it seemed completely contained within the tonsil.
Perfect. I think that's helpful to have just a quick 12-second discussion with the fellows that, I'm not a big fan of taking the tonsil out for a diagnostic biopsy in these situations. I see a lot of that in the community still. I still see a lot of our otolaryngologists doing that, taking out the tonsil in people that have a positive lymph node biopsy with FNA. And I really appreciate you highlighting that the first biopsy was non-diagnostic, because to me, the next step is to repeat the FNA or maybe even get a core needle biopsy to try to get a diagnosis without altering the patient and causing a tonsillectomy wound, to find the primary. And then you're going to take them back to try to take it out or give them full dose radiation to that tonsil. You're not buying them a whole lot. So just a quick soapbox right there.
No, just to add to that, I think it's super critical that you bring that up. And I think, Molly, it's, I think for us, for head and neck surgeons, this is something that we are used to seeing, kind of these younger folks with this type of thing. But when you talk about it, and whether it's boards or whatever it may be, I think it's just important, if your clinical suspicion is high, number one, that's why you repeated it. Number two, now we have a more specific and sensitive test that you can use to provide some backup to these P16 status.
Yeah, I've definitely had a few where it's so few cells they can't comment on P16, or so the NABDX has definitely been helpful. And if your site has it, similar to WashU, I did it with Cytopath on site if they've had a previous non-diagnostic, so they can at least see if there's sufficient material.
Excellent. Yeah, let's look at imaging.
So his PET, this is his CT component, because he had been seen like a month or two before. So I got updated imaging. And similar, you can see this tonsillar lesion here. I can pause it here. It looks like it's slightly into the GTS. Again, it feels like on palpation, it feels pretty contained to the tonsil itself. And then looking at this node, it's slightly larger than it was previously, but again, no other areas of concern, no other lymphadenopathy. His PET, he was moving his tongue, so the whole tongue lit up, but the radiologists were able to sort of window it in a way that they could tell the primary was in the tonsil. Yeah, it's my favorite. And then similar to Linda's case, the node was really not very avid. As you can see it here, but it wasn't impressive. It seemed very cystic, with very minimal FDG avidity.
Yeah, so you have this patient in your office, first equivocal biopsy. I'm glad you didn't take it out as a branchial cleft cyst. It's clearly not. What exam did you do for the tonsil to prove that it was there? Like you said, you couldn't see it very well. Could you palpate it?
Yeah, it was pretty firm on palpation, and that combined with that imaging, I think, was pretty convincing that it was going to be in the tonsil. And the tongue base felt soft; it didn't feel fixed, so I wasn't worried that I was going to get into a situation that was, creating a defect in the oropharynx that was going to be, not what I would have recommended had I known where it was. So I felt pretty comfortable with that. And then he had a single node, which we can talk about shortly about.
So right now, looking at this, it looks like nothing, no red flag saying don't operate. So he's got treatment options. What were your treatment considerations then?
So I talked to him about surgery versus chemoradiation, specifically just relating to the nodal size. So on his first image, it was 2 by 3 centimeters, and then we get CT, anatomic CTs with all of our pets. So he had a new CT, but they don't do coronal reconstructions. So you can see the axial reconstruction, it had grown 3 millimeters, but I didn't know like how much it had grown from a AP direction.
Okay.
And so I talked to him, that there is a chance that he may still need radiation depending on what the node showed. It's similar to the last case, didn't look like there's any E&E, it was very mobile. And so a single node and that looked very cystic. I was not super concerned that the actual tumor burden was going to be very large in this node, and he preferred to have surgery. And so that was the sort of discussion, and he was leaning towards surgery, which I thought he's a good surgical candidate.
Yeah.
So
You know,
me here and Harry, what are your thoughts on, is there really a difference between a 2.9 centimeter cystic node and a 3.3 centimeter cystic node
no, not at
in the
all.
management of these patients?
No, not at all. I mean, I think
Yeah.
a case like this, it would be a lot easier in our tumor board discussion to favor a surgical approach as opposed to the other, simply because you had the confounding effects of other nodes that suggested a much more higher nodal burden. And so this is a lateralized tumor with a single node. To me, I know I have colleagues that would say ipsilateral neck radiation plus or minus chemotherapy. But to me, this is an opportunity where there are some patients that back before 3311, there were many who thought TORS, and I know this is not the right audience to hear this, but it was a biopsy. And so surgery is actually potentially definitive in this case here. And because many of these patients are young, this is a case where I would certainly advocate for surgery. And if in fact we ended up needing to give adjuvant radiation, I think it opens up the question of whether or not our findings in arm B in 3311 are generalizable right now. And so I think that itself is an interesting conversation, and I'd be interested in hearing what others think.
Yeah,
I think that,
go ahead.
go ahead, Frank.
Go ahead,
I
Mayor.
was going to say,
please.
I think that one, everyone, the fellows on the call should really note that Harry is super progressive and one of the thought leaders in this, and you're not going to always find radiation oncologists who will say those things. That's the first thing that you really need to understand. So you got to really understand your literature and your evidence when you are coming to a multidisciplinary conference to discuss your treatment plan and algorithm. At our institution, we would also, Trevor, kind of what you're alluding to, probably only offer radiation therapy, just because that node, it's a continuum, and it's hard to make a cutoff to say, okay, this is the point at which you're going to add chemotherapy, or this is the point at which, it's a little bit arbitrary how you measure those distances, and our radiology colleagues or neuroradiologists, whoever's reading for you, are going to try to do the best they can to make it consistent. However, the true proof, I guess, and where that data comes from is on pathologic data. When you talk about what I'm guessing you're getting at, Trevor, is just the older editions of the staging system. When are we going to start to trigger radiation adjuvantly based on nodal disease? And again, that was an HPV negative disease.
Yep.
Excellent point.
It's a lesson to the fellows to always consider challenging the dogma. Just because you're told that we do something just because that's the way we've always done it. If we did that in surgery, we would still take breast cancer out by taking the chest wall and the ribs out. And so I think you have to always challenge the dogma. Are we doing what we're doing? How can we push it forward? And you've got some very forward thought thinkers at the panelists here who are pointing that out. And we've even done data that shows that the number of nodes of HPV negative probably matters more than the size. And so all these things should factor into really thinking about these things more thoughtfully.
Excellent points. Excellent points. I agree with all that. I don't think we've ever found that a 4-centimeter tumor does worse than a 2-centimeter tumor for HPV related diseases in the nodes. Maybe after we talk about what Molly did for the patient, I can ping Harry and see what his thoughts are if the tumor's 6.1 centimeters. Yeah.
Cystic, right? Cystic.
Yeah,
Make it
you
easier
got
for
it.
me.
You got it. So Molly, what'd you guys do?
So he was interested in surgery, and I thought that was, also the right decision if he was interested. So we did a TORS tonsillectomy and ipsilateral neck. His primary, he had a 1.5 centimeter HPV mediated tumor in the left tonsil, negative margins, no adverse features. He did have just the one node, but the tumor deposit was actually 3.6 centimeters. There was no ENE. And so that surprised me. I mean, given how cystic it was, and he had previously had a negative biopsy. And so he initially wanted to get treated in the community. And we have a couple of partners who are following 3311. So anyone who was in that intermediate arm, they'll de-escalate to 50. But then he got presented to our tumor board too. And so I guess some of the discussion points are, if you have just one node and it has a tumor deposit that's greater than 3 centimeters, which was previous N2A, which was included in that intermediate arm for 3311. Do you think there's a need for adjuvant therapy? And if so, what dose are we talking about? 50, 60, or that was one of the first question.
Yeah, it's an excellent question, because I think I always talk to my patients as we're adults here, and you have choices, right?
Yeah.
It's not, we're not going to hold you down and make you do a treatment you don't want to do. And we're not going to stop you from doing a treatment if there's potential benefits. So I think in a situation like this, a barely over 3 centimeter tumor, it's not unreasonable to consider radiation. I think the control rates are going to be higher, but if they fail and they don't have radiation, they can still get radiation. So there's two edges to the sword. So I think observation is reasonable in these patients, and I think adjuvant treatment's reasonable in these patients. And a lot of it just has to do with your team and the patient and their mentality going into it. I do feel that 50 gray is probably enough, and maybe even less is enough, and we'll find that in an adjuvant setting. Harry, what are your thoughts? Would you offer 50 gray to this patient, or would you recommend observation?
Well, I might be a bit biased. When we chose 50 gray, part of the thinking behind that was what we wanted to do is see, let me just as an aside, just make a quick commentary, because I know we want to stay on time. But a lot of the de-escalation, de-intensification efforts, and I distinguish the two differently, but everyone's driving, just dropping and dropping it. But remember, what we're trying to do is minimize tissue injury, and tissue injury as affects function. And what started all this was really swallow. And we really don't have a handle on what low is low to minimize that, because I think if we knew that, then we would have that threshold to know where to go towards, as opposed to going so low that we increase the risk of recurrences, or try to figure that out. So to answer your simple question, I think everyone, when they talk about whether or not to offer 50 versus 60, and they say, well, you need the purists would say you need a randomized phase 3 trial. First of all, that's never going to happen, right? Because the relapse rates are so low.
Oh, don't say that. Come on.
Come on. Yeah. I know. But you think about it, that is giving you, that asks for the fellows. That kind of design is asking for internal validity. What you're really needing to determine is external validity. That is, for Molly's patient, whether or not for this patient that walks through the door, as opposed to the same patient that walks through our door in Baltimore, is 50 gray sufficient for these criteria, these pathologic criteria. And it's the generalizability. And I think that itself is more determined upon everyone's experience, largely, hopefully publishing at some point, hey, this is our 50 gray experience, and these are the results. And we're still seeing something very similar to what we saw on 3311. I think that is the issue, and I'm cognizant of the fact that the number of patients that were in Arm B that got randomized to 50 is still fairly modest, and I think that's the very issue, and that's the conversation I have with patients. And in fact, when I plan the radiation, I actually kind of give them the option. Actually, I planned it like 50 plus then that 10 gray boost, and kind of leave it up to them to decide. I don't know what the right answer is, but I do believe that at least 50 gray causes a lot less xerostomia as opposed to 60 gray. And when I chose 50 gray, it was based upon endoscopically scoping a lot of these patients. And we have a technique where we create a dose gradient such that I can see the areas that I've been getting sort of 60, 70 versus areas that were getting 40, 50, and so. And I don't see devascularized tissue in that range, and that's why I chose 50. That was the simple reason. So
Excellent.
Thinking microvascular changes is the key. So I would offer 50.
Would you be comfortable with observation?
Yeah, I think that is entirely reasonable. I mean, when we created the criteria in 3311, truly it's just arbitrary.
Yeah.
I think it's not unreasonable, but Ryan, you mentioned the risk of recurrence. I think you have to think about not just the risk of recurrence, you have to think of the consequences, right? The challenge with neck recurrences is sometimes they may be a little bit more difficult all depending on where the node was, or and those are some of the technical factors I think you have to think about, and certainly the sidedness of a patient's neck and what they do for a living, and I think all those things have to factor in as well too.
Yep.
And that's a good point. I think Ryan, to your point, there's a difference when somebody recurs after radiation than when somebody recurs after surgery.
Oh, sure.
And it's and that so this institute at my institution, this patient's not getting radiotherapy. I'm following them, getting an NABDX. And if their NABDX is elevated, then that may be something that triggers. But here's what me here thinks on this. There is a risk of recurrence, but it's a neck recurrence and really that difficult to manage in the HPV patient that you manage surgically as it is would be for radiation recurrence. And if it's not, if it's basically the ability to go back in there and kind of do a revision surgery, and do you really think you sacrifice that patient's survival by risking that?
Absolutely.
I think that from a high level, we need to rethink our prognostic markers. That's kind of the first thing. And so then that will hopefully explain my thought process beyond. Is that while I do, and I think Ryan alluded to it a little bit, or Harry did at least, if someone recurs, yeah, we can salvage them. I think the implications for the patient, their family, make it tough. So that's kind of my thought there, which is why a little bit I would lean towards radiation in this setting, even with the negative ctDNA. At the recent meeting in Phoenix, there was about a 68% DFS for 2 years in a negative ctDNA after surgery, which is great. So those patients are doing well. But then there's that other 20 to 30% which recurred. That is, if we treat this patient with radiation in 3311, we know with 5-year almost follow-up, with long-term follow-up, we're talking 94% DFS. So that's a big difference when you think about the two in that setting. That's the only reason why for me. But I do think we could potentially go lower. We have a trial where we are de-escalating to 36 gray after a negative ctDNA. So at our institution, that's what the patient would get. I don't know what the right answer is. I just think that ultimately we do need to figure out a better prognostic set of markers, because this nodal size criteria is just not sufficient. And like many others have alluded to, they would potentially not radiate these patients. And I don't think that's the wrong answer. I just think that it's unfortunately we don't have the best guidance.
Yeah, I think an important fact that we don't know is what is the salvageability. Because if the salvageability is 90-something%, and you can bring that group that failed up to the group that didn't fail survival, then it's a no-brainer, right? You're going to preserve radiation treatment on a huge percentage of patients that don't need it, and you're going to salvage the ones that ultimately do. But we don't have that yet. And people like me here that are really smart are going to figure that out for us. So I love it. So Molly, why don't you wrap up with maybe a little bit of data, and then we'll move on to the next talk here, because she has some data on, granted it's retrospective, but how these patients are doing with one nodal metastasis.
Yeah. So this, I will credit you from hearing this discussion in fellowship, but I tell patients, you have a higher risk of recurrence. I think you used to quote 14%, which is from the paper out of WashU, which is retrospective, looking at patients who declined radiation for one node, which is obviously a biased cohort, but it was helpful. I have the flow chart on the next, which I think is helpful to see, but I can show you in a second. But he was very adamant that he did not want radiation, and our tumor board actually recommended observation. And then he also met with the local radiation oncologist who said they could do 50 or 60. And so he opted for observation. So we're just monitoring him closely, and we'll get his post-op NABDX is drawn, but not back. And so, if that came back positive, I'd probably tell him, to consider radiation more strongly. But I think likely this patient himself is not going to get radiation regardless of sort of what we recommend. But our tumor board, both our radiation oncologists felt very comfortable absorbing this. So this is sorry, go ahead.
No, go ahead.
Oh yeah, 2 papers, both retrospective, one out of WashU and then one multi-institutional, this one in out of UCSF mainly, that looked at patients who had a single node, and basically, so if you take all these patients, the ones who did not receive adjuvant therapy for a single node, 9 recurrences, so 15%, and then the majority of them, so 67, could be salvaged surgically, or with radiation or combination. And so that's usually what I tell patients, is that, you have about a 14% higher rate of a local recurrence, and the majority of these can be salvaged. Some cannot. And so I give this information to patients when our tumor board, gives the option, and go from there. And I would say a lot of patients don't want radiation. They'd sort of rather just closely monitor, but some are willing to do the 50 or 60.
Yeah, I think that's excellent. I think that goes to my point is this is somewhat generalizable, but it's not scientific in the fact that these numbers are so low, right? These patients are failing so few and far between. Even the ones that are observed just don't fail that often. I wish we had this on the scale of thousands, because we would show a huge difference in the recurrence events, the DFS. But again, what does that mean to the patient at the end of the day? We don't know yet. 2 unsuccessfully salvaged versus 1 in the other group. Like, there's just not enough patients to say that it's meaningful, but it could be very meaningful. We just don't know. And I wish we had that data.
Yeah, all you need is really good, large observational data for this.
Mm-hmm.
Yeah.
Molly alluded to something in that presentation, which was they're checking on NavDx, and if it comes back elevated, maybe consider radiation. With the only metric in our field for the Commission on Cancer being patients getting into radiation therapy 6 weeks after finishing surgery, how do you feel that all plays out with sort of people who have a positive NavDx and then all of a sudden tumor is flexing to do adjuvant radiation therapy and potentially missing that time window?
Yeah, the NavDx takes about 3 or so weeks to come back, so I get it at the first visit. We have a in-house one that's starting, which I think will be a little bit faster, and then I still have them meet with radiation oncology at least to establish a relationship, so that if that happens, they at least have been set up. And at least the local radiation oncologist was planning to do radiation if he wanted it. So I try and get the ball rolling. I tell them all to meet with the dentist. That's one of the big problems we have in terms of delay. And so I usually will tell them that before. So I try and eliminate as many of the sort of time obstacles as possible.
And to wrap up Molly's discussion, I think I'll finish with a lot of that recommendations based on HPV negative head and neck cancers. I don't know of any papers looking at HPV positive tumors. I know we've done this. Evan Grabois has written some good studies out of MUSC, and the HPV positive
Ryan,
patients,
3311 did.
Yeah, it doesn't seem to matter to start within 6 weeks as much.
The 6 weeks was defined pathologically by those who might be at higher risk. That the time to start the post-op radiation seemed to be much more relevant in those. And again, those were not distinguished by HPV status. So I would say that it's an important consideration, but I wouldn't say that there's a clear cutoff upon which one might then actually think that they're not going to so-called benefit from it.
Yeah.
Yeah.
So that delay, if NavDx becomes the new norm in the future after all these trials, then it might be worth the extra delay. Yeah,
and I don't believe the patients do lose benefit by delaying an HPV positive. That's not my belief. But when the Commission on Cancer makes a recommendation, it's more likely they're going to roll that out uniformly, and we need to think about that as a society and start to have these kind of publications come out so that we can pivot and decide how we want that metric to be weighed before somebody decides it for us.
Yep, great comments. Great discussion, everybody. There's going to be a lot coming forward on NavDx and liquid biopsies, et cetera, that we just don't know enough information about yet. So it's an exciting time to be a fellow and young faculty member. With that, why don't we move on to Ray to get started on his presentation. Again, Ray's coming from Baylor to visit with us tonight. So Ray, take it away. I don't hear you talking. You might be on mute.
Hi, can you hear me now?
Yep, we can hear you now. We
Okay.
can see your slides.
All right, sounds good. So my patient's a 71-year-old gentleman with hypertension and OSA. Actually was noted to have a left base of tongue mass on a DICE for an INSPIRE evaluation. Was sent to us after that, and was also noted to have neck lymphadenopathy, which had developed about 2 weeks prior to seeing us. Otherwise, relatively healthy, no past surgeries. He's a cigar a day smoker and drinks about 1 to 2 drinks a day. So on exam, he has this pretty exophytic 2 centimeter mass in the left base of tongue, which is pretty clearly palpable. It's very clearly free from the vallecula as well as a lateral pharyngeal wall, but it's pretty well lateralized here, but although pretty close to the midline on the medial aspect. So we actually biopsied multiple times. So you can see here, we actually did 3 rounds of frozen sections. We'd taken out basically half the tumor. By the time we actually got, we actually never actually got cancer on the frozen sections. It came back in the final permanent with the last section. So actually most of his tumor was just papilloma. Given that we weren't able to get the frozens, we actually did a FNA while he was in-house, which came back as squamous cell carcinoma, which was P16 positive. Looking at scans, unfortunately, he didn't get contrasted scans the first time, but you can sort of see this mass here within the left base of tongue, which is, again, pretty exophytic. And then he's got 2 nodes here. So you've got the one here, and then this is a second node just below it. And then similarly, a PET scan, again, you can see this kind of FDG avid mass in the left base of tongue, and then there's the 2 pathologic nodes there on the left side. Okay. So I think for this case, there are a couple of discussion points. So first is like management of the contralateral neck, and we've sort of gotten a little bit into that in the first case. But I think this is a big, hot topic, especially for, cancers of the base of tongue, and then kind of leading into how that affects the decision between TORS and chemoradiation.
Let's take a step back. Let's go back to your imaging. I think to me, these are the most challenging tumors that I deal with, are these glossotonsillar sulcus tumors. Much more challenging than do you treat both necks or one. It's harder to have a definitive algorithm on these just because there's so much involved. First step is, how do you examine this patient to determine if you should or even can take this tumor out?
Yeah, so there are, I guess, a couple things to look for. First thing is obviously palpation. So this tumor was pretty free from the tonsil, and then really, you have to get all the way down in your finger, all the way down to the vallecula to make sure that it's not involving the epiglottis. And similarly, I try to feel laterally to make sure that it's off the lateral pharyngeal wall. This tumor didn't seem very deep. The other thing also, I'll feel through the floor of mouth and try to feel there. For some of these tumors, you can actually feel the tumor through the floor of mouth, which is a sign of deeper invasion, which he didn't really have.
Yeah, I think the floor of mouth palpation is exceedingly important on these patients, because if they have tumor palpable in the floor of mouth, you're going to start getting into some hairy territory, not hairy quan territory, hairy situation territory. You might be getting into hairy territory too, because that patient might need some radiation treatments. But Mihir, from a surgical standpoint, you've done hundreds and hundreds of TORS cases. We've all made poor judgments or seemingly made great judgments, and you get into the operating room and things are different than you expect. What do you see in the glossotonsillar sulcus as being challenging from a surgical standpoint?
Yeah, it's funny that you requested to come back and look at it. And sometimes I wonder if we have the same brain. I was thinking the exact same thing. For me, these are without a doubt the most challenging tumors to tackle. And I tell every time our fellow comes through, I said I would take these with extreme caution, and I would not do these until later, until you're more comfortable, until you've figured out your workflow, for a number of reasons. And once you get in there, exposing it is a challenge. So getting the tumor on an appropriate stretch, or however you need to do to get that corner, see how that corner is going into what appears to be looking to a sulcus. And I know that Ray has mentioned he's already done appropriate palpation and has verified that it has not in this case. I'm saying in the case when it does, the problem here is that you're dealing with essentially what I think of as three subunits anatomically. You've got some base of tongue action, you've got the lateral pharyngeal wall action, and you've got to consider the tonsil as well, because you got to get a margin. While we know it's going to be close, 1 millimeter, whatever that might be, the deep margin on these cases will be centered on the styloglossus muscle, and that muscle is going to retract when you disrupt it from the styloid and when you disrupt it from the tongue base, and it is going to potentially make what is actually a negative margin positive depending on how it's processed. So all these little nuances need to be thought of. And then that also has significant impact on immediate postoperative swallow function when you lose that retraction that styloglossus provides. So you're dealing with this in multiple layers of potential complications, from not just the technical aspect, but the early post-surgical perioperative rehabilitation aspect.
Yeah. And in my experience, I echo everything he said. And I think these are the most dangerous tumors we take out, because lingual nerves intimately involved here. The lingual artery, hypoglossal nerve is not far, especially if you're starting to get toward digastric muscle. Facial artery is right there. You often see it. You're often looking at the submandibular gland or components of that space. So now you're at risk of a pharyngotomy when you put your arm in AV in or something to retract for your neck dissection. So it's a tumor that's small, T1 in size, but it may be harder to take out than a big T3 tumor just because of the surrounding anatomy. So it's just something to really study your exam and your scans. So I appreciate that, Mihir. Very, very helpful for the fellows, I think. So Ray, why don't you continue on here?
Yeah, so I guess we can talk about the actual case. So we did talk about it in our tumor board conference. I think he actually would have been a pretty reasonable candidate. We did the original biopsies. We actually did it with the FK retractor to kind of see what his exposure would look like. And we actually were able to get a pretty good view. It's a little bit further down, so it's not quite attached to the tonsil. But I think at this point we were just getting set up at the VA with the SP. So this would have been the first case at that hospital with the SP, which neither of us were particularly thrilled about. He really wanted to get therapy as soon as possible. So he ended up getting recommended for chemoradiation.
Yeah. So Harry, Ray's considerations here are management of the contralateral neck, and I think that's exceedingly important. We've talked about two cases now that are lateralized tumors, very lateralized tumors. I think many of us feel comfortable treating the ipsilateral neck there, even many of our radiation oncologists. There are nuances there, no doubt. But in this case, this is not a lateralized tumor. He showed an image of it being on the lingual tonsil. It's not crossing midline, but it's definitely not lateralized. What are your thoughts on the contralateral neck from a radiation standpoint, both in a primary setting and in an adjuvant setting?
Yeah, the traditional mantra in radiation oncology is tongue-based meat equals bilateral neck, which is not necessarily true. I mean, at what point do we start to have that increased contralateral risk relapse is not clear. In fact, for 3311, this became a point because there were so many that were wanting to treat ipsilaterally for a lot of these GTS tumors. And our study design was based upon relapse rates for bilateral neck radiation, as such that we were concerned that we were going to be compromising our power calculation, because if we were to allow ipsilateral neck radiation for these, in the end, we actually did. And that's actually what the results reflect. How many of those were actually radiated this way? We haven't gone back, but we've now got mature results that we should actually go back and take a look at from the point of view of IPSI versus bilateral neck. So the simple answer is, I don't know, Ryan, but I will say that more and more of these cases, I do just treat ipsilaterally and I watch them. And my personal experience is the fact that the risk on the contralateral neck failure is really low. I haven't had a recurrence that I've remembered, and we try to score everyone in our database. And to that extent, I think that if I had to guess, it really is when tumor is really coming more to it's involving the mucosa and to at midline, if not beyond.
Yeah, and I think that's what our data would show too. We published a paper with a really good resident handful of years ago, looking at occult nodal metastases in these tongue-based cancers. We often dissect the other neck here at WashU. It's just our practice pattern that we spare radiation to the other neck if it's pathologically node negative. So we had many patients, I think 70-something patients get bilateral neck dissections for tongue-based tumors. And the occult rate was close to 0 in the GTS tumors, but was over 20% in the midline tumors. The problem is we don't have.
How did you define midline again in that paper?
I don't remember the exact number.
Yeah.
But the closer the tumor got to midline, the higher the rate. But again, we don't have thousands of tumors to say where is the cutoff. It's like that node size. At what size node do you finally say it's time to bite the bullet? I wish we knew that, because we could save patients a lot of morbidity, either with neck numbness and shoulder weakness on the other side from surgery, or from xerostomia and dysphagia from radiation treatments.
I do want to just give I just wanted to give a quick nod to John Del Media and the Canadians who have Select 11, or now it's a trial opened with NRG as well, HN11, where they are using LymphoSeq to inject the various sites in these lateralized tumors, including this exact type of tumor, to see where the LymphoSeq tracks. And then if it tracks ipsilateral, those patients are randomized to ipsilateral radiation or bilateral radiation. I think hopefully it'll do these things that you have done already, Ryan, at your institution, and kind of demonstrating the pathology, but then Harry also marrying that with what you're doing clinically with your patients, and hopefully provide us with some meaningful algorithm to say, okay, look, we're only going to radiate this ipsilateral neck based on what we see here.
Yeah, that's excellent. So we're all surgeons. I think everybody's surgeons in the audience, at least a large portion. We all know the side effects of neck dissections. We all know the risks. For fellows that don't do a lot of clinic, a lot of them have numbness. That's a big thing that they can complain about. But we all understand cranial nerve 11, 12, et cetera, weakness and the risks of that. Harry, what's the difference between ipsilateral and bilateral radiation? even when you're talking 56 gray or 54 gray.
Oh, huge. So we've done a lot of work on xerostomia and with a lot of data science approaches to really understand the spatial effects of radiation in the parotid glands. Essentially, what we now know is that the story is that saliva function is 50-50, at least for the parotid, contributing to the daytime saliva as we measure it, and so that's big. And so we also know that dose to the upper part of the parotid gland is more likely to impact on the ability to recover from the xerostomia, and that is very much dose dependent. And that is, we think that actually this is getting at the very least progenitor cells that actually are responsible for the repair phenomenon. And we think we have a rough idea where it is, and we don't. So whenever you are radiating both sides, you're increasing the chance, therefore, that you're going to also not only cause what I call an injury signal, that is the inducing perception of xerostomia, that is no flow or less flow, but you're also going to decreasing the chance of the patient having any functional recovery or reserve because you're impacting on both parotid glands. So
yeah, what do you think about the difference between 60 gray, 50 gray, 40 gray in that contralateral elective neck? Because radiation is starting to be limited on how low it can go without surgery, but we don't know the floor yet with how low we can go with surgery, and people are pushing the boundaries. ECOG 3311 at 50 gray. We did a study at 42 gray. Mayo Clinic's doing, granted, accelerated treatment, but in the 30 gray range. What are your thoughts there?
I think it will make a difference. And that, and to me, actually is one of the biggest drivers for de-intensification, which is my choice of words for, sorry, de-escalation, which is actually my choice of words for the radiotherapy dose component of the de-intensification. I think the lower dose you deliver to the neck nodes, the less likely, or it's much easier to control the dose to the critical regions where we think those repair cells are. And our studies have suggested that the threshold for causing what we call recoverable xerostomia versus unrecoverable xerostomia, about 18 to 24 months, is about 10 gray. And so you can see that if you are delivering only, say, 30 or 40 gray, you're going to be more likely to be able to keep that dose level in those critical regions. Right now, we don't know exactly where it is, but we have a rough idea. And then it still requires individuals to carefully be able to reduce the dose. So the lower you go, it just makes it a lot easier for anyone to keep the product function.
Yeah. So last question on this topic until we continue to move on. I want to ping Mahir. At Wash U, we're very big proponents of electively treating the other neck with surgery right now. And I think that's important at a certain level. And like Harry was saying, the lower we go on the radiation, the more I might change my mind, and Wade Thorstad might change his mind. And a lot of us, for a patient with bilateral adenopathy, this patient does not have that. But if a patient has bilateral level 2 nodes, I think many of us err toward the side of just treating that patient with chemoradiation therapy, because they're going to get 60 gray of adjuvant treatment right now at most institutions. That's probably not a low enough dose to put them through bilateral neck dissections plus a primary resection. At what dose do you think we should do surgery? Do you think if a patient got bilateral neck radiation to 40 gray, surgery's back on the table? Or 30 gray, surgery's back on the table? What are your thoughts there?
Yeah, that's a tough one. I mean, I think it's absolutely thought-provoking, particularly when you think of the 30 Rock trial, things of that nature. And ultimately, it all comes down to, number one, for me, progression-free survival. And how are we doing with that? So I think it is important to consider not just 2 years, but actually in this disease, you've got to really consider 4 or 5 years. Yep. And then as you talk about the quality of life aspect, which is what you're kind of getting at with the dose of radiation, I think that if you're under 40 gray, I would be hesitant to offer surgery if you're talking about similar progression-free, disease-free survival. I just don't think or have seen anything that is close to that in terms of progression-free survival.
Yeah, and I'm talking more about a patient has a T1 midline tongue-based tumor and a 1.5 centimeter met in each neck, right neck and left neck. I think if we can get down in the 30s gray, surgery may be better than definitive chemoradiation in that situation with adjuvant treatment, because if you can get down to 30 gray instead of 70 or 30 gray instead of 60, that's a big difference to those parotid glands, like you were saying, and to the constrictor muscles.
Sorry, I misunderstood. Yeah, absolutely. I agree with that. Yeah.
So I think these young
earlier, that gets to a different point me here making earlier, is that it may not be all about size, it's about biology and prognostic factors. Right. You might have a small 1.5 centimeter HB positive cancer is very high risk. You may have a larger node that's low risk. Right now, our risk is stratified by size, but what if it's something different? And I think that's where the biology probably will matter more than the size.
Yeah. So that's something, food for thought, that we'll probably know more of an answer to in 5 years from now than we do now. But Ray, we've talked a lot about the differences between radiation and chemo and surgery with management of this neck electively. What did you guys ultimately do at Baylor for this patient? They have a non-lateralized tumor with ipsilateral nodal disease. It looks resectable. What was your decision points?
Yeah, there were a couple. So, first one, like you talked about, this is kind of a tough case, and doing it as the first one at the institution was not ideal. The other thing was, I did ask the radiation oncologist. So, I did fellowship at WashU, so I was trying to kind of bring that mindset. And there is some debate within the radiation department there, but I think for the most part, most people would have still done radiation to bilateral necks, even if the contralateral neck were negative on that dissection. And those, for the most part, would be 60 or 66 grade, depending on who did it. So I felt that in that case, 60 grade plus a neck dissection or 66 grade plus is definitely not better than, chemo radiation. And it'd be even worse if he had, E&E, for example, from one of those nodes. So since, there's not a strong history of surgical treatment for oropharynx cancer here, which we're trying to work on. So I think most of our radiation medical oncologists are kind of on the conservative side. So given that, we wanted to go more for the chemo radiation route.
I think that brings up great points, right? Because we all practice in different locations. We all have different comfort levels in our practice patterns as a group. And this is a multidisciplinary event. I radiated here at my institution than one that's getting radiated out in the community, because like you said, they may give 60 to 66 grade to that other neck no matter what I do. There's zero reason for me to operate on that other neck. Versus here, I have a 9 out of 10 chance of them not needing any adjuvant treatment to the other neck. So it makes a lot of sense for me to operate on the other neck electively, because it really may change their function long term. So I think that's a very important point. And I think another important point is, you're somewhat humble in this humility, but you're just now getting started in TORS on your own at an institution that is developing this, right? Do you want this to be your first case where it's somewhat controversial? It's a tongue-based tumor, contralateral neck discussions. Might not be the best first case until you have experience and confidence, both in yourself as in your institution. Mihir, what are your thoughts on that? Did they make the right or wrong decision, or is there a right or wrong decision?
I think given the environment, you definitely need to understand your landscape and exactly what Ryan is wanting to. That is a critical piece of this, because if you had gotten a positive margin, or if something had just whatever had gone awry, then you almost essentially shut the door to TORS for many years to come. And the growth of the program is really dependent on you and in the cases you pick early on. And I think the fact that you had the wherewithal to not take on this case is very commendable.
Yeah, I mean, to add to that, you're fighting against essentially mantra that many radiation oncologists were trained, and I was trained, that rather knee-jerk response that is tongue-based, therefore bilateral neck, but the concept of a GTS tumor, which in my opinion is actually the primary site for occult primers, by the way. And I go looking for it when it's an unknown primer in this area here. Many do not distinguish this anatomically, and a big part of this is actually the endoscopic skills do not exist in the head and neck radiation oncology community by and large.
Yeah, very important point. Mihir, any closing remarks on this? Ray, did you have any other slides, or was that?
This is the last slide.
I think those were excellent points. I think the more midline the tumor is, the more challenging the decision making is, and the more you have to understand your multidisciplinary team, because you're not the only one treating this patient. So you really have to be on the same page, and it's going to impact what you do. Because if you don't dissect that other neck, they need to be aware of that so they can radiate it. But if they're going to radiate it anyway, there's no reason to do the elective neck dissection on that patient. So really understand your team, because there's no right way to treat this. There's a lot of right ways to treat this. Mihir, any closing remarks, any words of wisdom from a surgical standpoint? And then we'll finish with Harry for words of wisdom to the fellows from a radiation standpoint.
No, I really think that there were so many pearls here that were basically distributed by all the panelists. I think they did a phenomenal job. And I think if you go back actually and just rewatch this, you'll kind of pick up on some of them. Again, it's just like, you know, I really think that, you know, there's not much more to add other than just this case really does show, I think, high level decision making that is, you know, again, beyond the years of, I would have tackled this and made the mistake of doing it. And in fact, I have. And so the fact that you did not is, again, really impressive.
Great. Harry, what are your thoughts?
Well,
Reverse RT. What's the crystal ball here?
Radiation can cure everything, right? I mean, that's yeah, right.
Except for ORN.
Yeah, that's right. No, look, to the fellows, look, I think your field has done a lot better job of training you to think about the other treatment modalities far more than the training that the other modalities do. And I applaud AHNS, including forums like this. It's this very issue that allows you to be a lot more, nuanced in terms of your thinking. And to me, I think that statement, I just want to go on record in saying that I've always enjoyed actually being part of these forums. I think I like to think that I think anatomically, and for that reason, I just want to encourage everyone to continue to heed Ryan's advice, and that what you want to do is go out and continue to learn beyond your surgical specialty. You will be a better head and neck physician. That's probably more of a very high level commentary. I think that from the point of view of TORS, I think Pathos is going to really help us really understand a lot of the adjuvant therapy paradigm. It will help establish that, because it's a trial that's aiming for over 1,100 patients, and it's going to be practice changing. And so I think that collectively, we're really going to really know how to treat these patients, at least have a new standard potentially. And then we look forward to future trials from your generation to be able to further ask new questions and establish new standards.
Excellent. Now, thank you guys so much. I want to thank our special guests here, Mihir Patel and Harry Kwan, definitely experts in their chosen field here, and a lot of insight. And I want to thank our panelists. They did an excellent job with really good cases. You know, I wish we had 3 hours we could talk about on primaries. We could talk about so many different topics that are controversial and good for fellows to hear, but there's only so much time. So join these talks every month. You'll get a lot of pearls out of these, whether it's the endocrine section or whoever else is giving the panel. I think there's a lot of important information that comes out of these that the fellows can gain from. So thanks, Ray and Molly and everybody for joining. Is Linda still on? Thank you. Yeah, Linda's still on. And Tony, thanks for allowing the mucosal section to sponsor this month's event.
Well, it's not me, it's our service. And thank you so much, Ryan and Trevor, for doing a great job. I personally learned a lot. And fortunately, there were some positive comments for Canada too. So that's wonderful. Thanks, Mihir, for that. All right, guys, everyone have a great night. And please share this amongst your fellows, and it will be available online as well.
Thanks, Tony. And thanks everybody for joining.
Thank you.